You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 3rd, 2023. This week, AFib ablation, renal denervation, Omecamtiv Mecarbil, and an ACC preview. The first topic today is AFib ablation, and I'm going to lead the podcast with an observational study. Many listeners might have had the impression that this podcast is a thing against observational studies. I do not. The problem I've had many times over with observational studies is the inappropriate attempt to make causal inferences from these non-random comparisons. Remember, science tells us what we can do, trials tell us what we should do, and registries, observational studies tell us what we are doing. The study today I cover did not try to polish a non-random comparison with statistical adjustments. Instead, it told us what is happening in AF ablation in the U.S. Well, in a sample of hospitals that voluntarily participated in the registry at least. The journal, the American College of Cardiology, has published the first report from the newly created NCDR-AF Ablation Registry, which began collecting data in 2016. And I know that seems weird, right? Because AF ablation began around 2000, and I started ablating in 2004. Now, there was a bit of consternation getting this registry going. That's inside baseball that I'll leave out. The main point is that participation in the registries is voluntary, and that's a fact that bears on translation of the data that I'll come back to. The report included 76,000 patients who had AF ablation between 2016 and 2020. The main findings: most patients who get ablation are young, the mean age 65, mostly male. Slightly more than half had paroxysmal AFib, and the mean CHA2DS2-VASc score is 2.7. Redo procedures were about 20%. Now, the registry included 708 doctors at 162 hospitals, which seems like a lot, and it is. And this is the biggest AFib registry, but it also is less than one-third that of the nearly 500 hospitals that participate in the mandatory NCDR registry for left atrial appendage occlusion. Success rates for achieving pulmonary vein isolation was only 92%, which is quite weird because I don't think I've ever left a PV not isolated. Complications during the procedural hospitalizations was 2.5%. Major complications was 0.9%. Hospitalization greater than 1 day occurred in about 1 in 10 patients, and procedural volume of the participating hospitals was pretty impressive at a median of 130 cases per year. But again, remember, voluntary registry. Now, my comments. This leads to podcast because this is a great use of observational data. That is to tell us what we are doing and not to make seriously flawed, non-random comparisons. The results are mostly in line with what we would have expected. Now, one exception is that I would have expected near 100% PVI. Almost 1 in 10 cases in this registry did not achieve PVI, and I don't know how that happens. It's surprising. Regarding the demographics, I'm not surprised. Most patients we ablate have some risk factors, hence the CHA2DS2-VASc score of nearly 3. And a comment on male predominance. There is this notion that males get more AFib than females, and that may be true, but at Western AFib, Professor Christine Albert from Cedars-Sinai presented really interesting data that when you adjust for height and weight, remember females are smaller, the male-female difference in AFib goes away. Her thesis was that there may not be any sex difference in AFib prevalence. It may simply just be a matter of size. It was a really interesting talk she gave. Redo procedures are also in line with my expectations. 20% is way down from what it used to be. Gosh, it used to be almost 50% of patients went back for a second ablation. I think that's because we're better at PV isolation now. Major complications at 0.9% is likely an underestimate because of selection bias, wherein the registry was voluntary and most of the centers who participated were large, high-volume centers. I suspect, as you do probably, most ablation in the U.S. is done at low-volume centers and complications would be higher. Also, the registry only captures inpatient complications. The most feared complication of esophageal thermal injury occurs many weeks later. This registry also does not include any data on success rates, and boy, to get that would be a massive undertaking. I don't even know how you would. I would say that this is a great start, and it's always good to have data on what we are actually doing. But the non-random sampling of only hospitals that volunteer to participate should push us to consider these data as a best-case scenario. We surely learn a lot more from mandatory registries, but those sorts of decisions are policy matters above the scope of this podcast. I would say congratulations to the authors led by Jonathan Shu from the UCSD. Second topic, renal denervation. Oh boy. JAMA has published results from another sham-controlled trial of renal denervation for hypertension. Radiance 2 studied the efficacy and safety of renal denervation with an ultrasound catheter in about 220 patients with hypertension at 61 centers. It was a 2-to-1 randomization. Patients were withdrawn from their meds during a run-in period and then for 2 months post-procedure. And at 2 months follow-up, the difference in daytime ambulatory systolic blood pressure was about 6 millimeters of mercury lower in the renal denervation arm, and that was statistically significant. There were no major adverse events at 2 months. Simultaneously, the journal JAMA Cardiology published a patient-level pooled meta-analysis of the 3 Radiance trials. There was Radiance 2, Radiance Hypertension Solo, Radiance Hypertension Trio, and these were all trials using this ultrasound catheter, and they were all sham-controlled. It's included 506 patients in the 3 studies, and again, at 2 months, the pooled, sham-controlled systolic blood pressure reduction was consistent across trials of about 6 millimeters of mercury. Now, my comments. I hardly need to opine much on this because JAMA has included a thankfully short and clear editorial from legends in the field, Drs. Clyde Yancey, Greg Faudereau, and Patrick O'Gara. Their title of the editorial was good. That's what we all want to know. Quote, is there a role for renal denervation in the treatment of hypertension? Let me quote them a couple sentences. Quote, in anticipation of possible near-term approval from FDA for renal denervation, there must be an insistence on longer-term clinical outcomes and safety data. Disease-modifying, readily available, and easily affordable medical therapies for hypertension are ubiquitous and set a high bar for any new therapeutic. Quote, the magnitude of blood pressure reduction attributable to ultrasound renal denervation approximates that of the addition of a single other drug class and is likely less than the addition of an MRA drug. Finally, device-based treatment of hypertension may be an intriguing iterative step, but perhaps ideal blood pressure awaits better implementation strategies with available therapies and early-age primordial prevention. My gosh, these are great comments, and it's really not so common to have such sober and clear comments in a big journal editorial. Now, they do use some big words, so let me simplify into more easy words. Okay, here's what I would say. Hypertension is a huge public health problem. It perhaps rivals obesity as the most pressing cardiovascular problem today. I would also say people don't like taking lifetime medicines. I can't remember to take my puffer, and I have symptomatic wheezing. A device-based approach that would reduce blood pressure and the need for medicines would be a huge advance. Though these ultra short-term studies are a start, but blood pressure therapy isn't for months, it's for years and decades. And so, okay, we know from these studies that ultrasound renal denervation provides a statistically significant 6 millimeter drop, but that really is a modest drop, and it's likely less than a pill like spironolactone could do that costs pennies. Now, what I say next, I think, is the most important sentences of this podcast. Here it goes. We have no, and I mean no, reliable data beyond 6 months for any renal denervation therapy. And I know proponents may argue that we do, but they are wrong, because the studies that purport to show long-term blood pressure effects are fatally flawed because they unblind patients. And once you unblind patients, you're back to the pre-Simplicity 3 days when renal denervation looked amazing. Now, I want to reiterate, the science is good here. What I worry about is if the FDA lets this on the market without adequate long-term data, I think it would be a disaster. I mean, rapturous doctors who love procedures would flock to doing this easy procedure. I think regulators need far more data on long-term efficacy before releasing the device into the Wild West. And yes, I hesitate to say this, but doctors need regulators to save us from ourselves. Okay, third topic is very brief. Omecamtiv Mecarbil, the first selective cardiac myosin activator, joins the heap of positive inotropes that don't help patients with heart failure. FDA declined to approve the drug, citing a lack of evidence for efficacy. But recall that the GALACTIC-HF trial was technically positive, with Omecamtiv Mecarbil reducing the primary endpoint of first heart failure visit or CV death. That hazard ratio was 0.92, an 8% reduction, with 95% confidence intervals ranging from 0.86 to 0.99 and a p-value of 0.03. But FDA felt it was a very small reduction in the primary endpoint. It was driven by heart failure visits. There were no differences in CV death, all-cause death, or quality of life. So the FDA was not sufficiently persuasive, and I would agree. The AdCom advisory meeting voted 8-3 against. The company that makes the drug said it had no plans to do another trial. Instead, it placed focus on development of Omecamtiv, the next-in-class cardiac myosin inhibitor, currently subject of the SEQUOIA-HCM clinical trial in patients with an obstructive hypertrophic cardiomyopathy. The take-home is simple. Big breakthroughs in this modern era are hard because of the progress we've already made. All right, the last topic today is the ACC Preview, which actually starts tomorrow in New Orleans. And I'm taping this at like 3:30 a.m. because I have an early flight to New Orleans. So if you're in New Orleans, please say hello. Last week, I covered the lead trial on the first day of the ACC, which is tomorrow, clear outcomes of bempedoic acid. And I also mentioned this in my ACC Preview column, which is up at theheart.org, Medscape Cardiology. Please take a look at those. One brief thing that I failed to mention about the study, clear outcomes, is always look at the baseline LDL of this trial. I don't know what it is, but the higher it is, the more likely that there will be a benefit on outcomes, right? Sanjay Kaul was tweeting about this recently. For instance, one of the reasons that ezetimibe may have looked so measly in the IMPROVE-IT trial was only a 6% reduction in outcomes was that the baseline LDL in IMPROVE-IT was only in the mid-90s. So there's a big attributable fraction of effect based on LDL. So just look at the baseline LDL to assess what the degree of benefit is. And of course, we know there's benefit because the company has already announced that it's met its primary outcome. Okay, I'm going to move on, but I want to say one final thing. The more I think about this bempedoic acid trial, the more I worry about spin. The spin in terms of ginning up statin intolerance awareness. Now, statin intolerance really isn't resistant to a placebo control. I also worry about spin in accentuating the outcomes. And I may be wrong. The ATP citrate lyase inhibitor bempedoic acid could really have reduced MACE by a lot. Just everyone be careful. Really look at the drivers of the primary endpoint. Okay, speaking of spin, let's talk tricuspid valve interventions. At ACC, we will learn the results of the TRILUMINATE pivotal trial of transcutaneous edge-to-edge repair for tricuspid regurgitation. We know from a single-arm study published in 2021 that this Abbott TriClip system was able to reduce TR in about 85 patients, and it was also durable up to 1 year. But to judge benefits, you need randomization. Well, you actually need more than that. You need sham-controlled blinding and strong endpoints, but we're only going to have to settle here for randomization alone. TRILUMINATE Pivotal is a 700-patient RCT of patients with TR who will either have the clip or medical therapy. The primary endpoint is a hierarchical composite of all-cause mortality, or the number who have tricuspid valve surgery or heart failure hospitalizations, and an assessment of quality of life. There'll be secondary endpoints like change in TR, change in quality of life, and 6-minute walk test. Now, my comments. I'm going to bet my Pinarillo that this is going to be a positive trial. There's no sham control, and quality of life is an endpoint. There would be no possibility of blinding readers of the echoes because you can see the clip. But you could at least blind patients, right? Here is why. Patients in the medical arm will have what Christopher Raj Kumar from Imperial College London has termed subtraction anxiety. I'll link to that paper. They show that in the FAME-2 trial, FAME-2 of FFR-guided PCI versus medical therapy, that patients who had severe coronary stenoses who were randomized to medical therapy had subtraction anxiety from the PCI group. They had far more urgent revascularizations. Of course, they did because they had a blockage that they knew wasn't fixed. So anytime they had a twinge of chest pain, went to the ER, they immediately went for urgent revascularization. So it'll be the same here in TRILUMINATE. Patients in the medical arm know they have severe TR, enough TR to get in the trial, but they are not fixed. So they're probably going to be more likely to be admitted for heart failure, and they're surely less likely to report better quality of life. Quality of life as an endpoint is about useless without a sham control, period. Now, I don't know the results, and to be fair, this is a hard thing to study, TR. The problem with TR is even more difficult than MR because TR is even more ubiquitous. And most TR is secondary to RV dilatation and failure, aka secondary tricuspid regurgitation. Okay, my friends, here is the tension. Here's the tension. There are, I'm sure of it, a very small number of patients in whom TR is a primary problem and fixing it would be helpful, very helpful. So you would love to have technology to do it without surgery since surgery is so risky and invasive. We would say there is an unmet need. But, again, industry isn't interested in developing a technology to help a handful of patients. When this trial is positive, there will be tricuspid regurgitation awareness programs. Heck, we may even have a tricuspid regurgitation month. There'll be a push to do this procedure in oodles more patients with TR, and cardiology clinics we know overflow with patients with TR, and interventionalists like to intervene. Now, I don't know the solution to this tension, but if this TriClip thing is overused, as it likely will be, it won't be the company's fault. It won't be the TriClip's fault. The fault of low-value tricuspid valve clipping will be on the overly rapturous doctors and, of course, the fee-for-service incentive structure to do more procedures. One thing that might be fun to look at a year or two from now is we could look at tricuspid valve interventions in cost-constrained systems like that in the UK or Canada versus the US. Okay, implementation science. ACC will feature a really important and sort of new field of medical science. Implementation science studies the ways in which evidence is best used in routine practice. In my column, I use the example of the STRONG HF trial. Remember this one? This is one of the strongest trials of the year. STRONG HF found that patients who had heart failure who were randomly assigned to a high-intensity arm after hospitalization for heart failure sustained a clinically and statistically significant 34% reduction in heart failure readmissions or death compared with standard care. The problem is that few hospital systems could implement such an intense program of multiple cardiology visits after discharge. There will be at ACC 6 major studies reporting that look at ways to deliver therapies that have evidence for benefit. Okay, I know. I'd better stop lest you stop listening. It's not that exciting implementation science. It's unlikely to ever garner a round of applause, say like the MitraClip trial. But it is vital these days to find the best ways to deliver beneficial therapies in our complex systems. If MitraClip is steak, implementation science are the vegetables. Okay, speaking of MitraClip, one of the featured studies from ACC will include a 5-year report from COAPT. Remember COAPT? That compared medical therapy to MitraClip in patients with secondary MR. You recall also it was decidedly positive, almost as good as clean drinking water and antibiotics, while a similar RCT called MITRA-FR from France and government-funded was totally null. Now, proponents of MitraClip argue that it has to do with patient selection. If you pick exactly the right patient with disproportionate MR, then you can get benefit. Okay, maybe. Anyways, 2-year results of COAPT were great. I don't know why meds would look any better at 5 years. One thing we might look at is whether the effect size is attenuated. Structural interventions will surely be a great development. They are a great development. The problem is it's the same for TR. It's how many patients will benefit. It is surely not zero, but I suspect it is a lot lower than most interventionalists believe it is. All right, sports cardiology. I like sports, and I understand endurance athletes because I'm like one of those people who are a gerbil who needs to run on the wheel every day. I mean, I'd run on the wheel without any apps, but the apps that we have make it better. ACC will feature numerous papers on returning to sport. One in particular centers on patients with hypertrophic cardiomyopathy. Another, return to sport on patients with genetic channelopathies. Okay, final thing I'm looking at for ACC is attendance. How does it feel at ACC? How will it feel there? As I wrote in my preview column, I worry about the future of these mega meetings. More and more, I see that young doctors presenting their posters and old professors who are always on the speaking circuit and industry. What I don't see is the rank and file of working stiff doctors who used to go to these meetings for CME. Things have changed, right? Most doctors are employed. We're in an RVU model. There isn't the luxury of days away. What's more, it's not cheap to fly to and stay in places like New Orleans, San Francisco, Chicago, Boston, etc. And another thing that may be driving down attendance is cheerleading rather than serious debate and appraisal. Scientists presenting at Late Breakers now face a congratulatory panel. People say, "Congratulations, great study." But of all the studies that deserve robust, dispassionate critical appraisal are the ones that will make the news, like the Late Breakers. I, for one, would love to see less agreement and more critical appraisal, like the editorial I described above on ultrasound renal denervation. I'd like to see more speaking with clear language. This would do a lot, perhaps, to bring regular doctors back. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And hopefully I'll see you in New Orleans. Please say hi. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.